The views and opinions expressed in this podcast episode are solely those of the individuals participating and do not necessarily reflect the views or opinions of Riverbend Media Group or the Riverbend Awareness Project, its affiliates, or its employees. It is important to note that the discussion presented is for informational purposes only and should not be construed as medical advice. Listeners are encouraged to consult with qualified healthcare professionals for any medical concerns or decisions. The Riverbend Awareness Project is a product of Riverbend Media Group.
Welcome back to the Riverbend Awareness Project. Today, Dr. Steve Vincent from Eastern Idaho Neurology has come to talk to us about multiple sclerosis.
Hi.
Thank you so much for coming in.
You're welcome. Thanks for having me.
Yeah, we're excited to learn more and hear your experience and knowledge. So, how did you become interested in neurology and MS?
Well, I was a computer programmer and started working with neural networks back in the days when computers really didn't have enough power. So I decided to study squishyware, the brain. It's not hardware. It's not firmware. It's kind of squishyware. And so I went to, I took my pre-meds, went to medical school in Chicago, and then neurology really was the right next move. I mean, it's like biocomputing. So I just found it fascinating. And then came here because I interviewed in a lot of places, and Eastern Idaho was just felt like home.
Well, we're glad you're here. Sorry.
Sorry. We were doing a little bit of research before we asked you to come in, and we read about how MS is an autoimmune disorder, but it also affects the brain. Is there any other systems that multiple sclerosis affects?
Well, yeah, it's the central nervous system. So that's the brain and spinal cord. And it doesn't affect the peripheral nervous system. That would be like the nerves that are in your arms and legs. You may have an arm or leg symptom, but it's not because those nerves on the outside are affected. It's just those nerves connect to central nerves, and they're the ones that are impacted. So brain and spinal cord is really what it's affecting.
Okay, so it's like the communications between those ones that get affected are then impacted down the line, kind of?
If you touch something, there's peripheral nerves that are sensing it, but it has to then relay it to the central nervous system to bring it up to the brain.
So when I think of immune system, I think of like getting sick, So like just getting a cold or getting the flu. Does that have anything to do? Like, is the autoimmune system different than the immune system? Sorry, I'm totally clueless here.
No. So the immune system, you're right. Its job is to protect us, but for reasons we don't fully understand, our immune systems make mistakes. Another thing we don't really understand is why women get autoimmune diseases more often than men do. And the ratio, depending on what study you look at, can be as much as 3-to-1 when it comes to multiple sclerosis. And so in MS, your immune system's attacking the central nervous system. If it was attacking your joints, it might be lupus. And if it was your skin, it might be psoriasis. But they're all a similar mechanism in that your immune system is supposed to be protecting us against foreign stuff. It's supposed to know the difference between that and you.
Are there different types of multiple sclerosis?
Yes, there are. So the most common is relapsing remitting. So what they mean by that is that you get an attack. Your immune system, again, is kind of messed up and attacks you. And then you get symptoms after which you improve. Now, you don't necessarily improve completely. If you did, then MS would be just annoying. But unfortunately, you don't really fully improve, and you accumulate something, even if it's too subtle for you to notice. And then you get attacked again later. It could be months later. It could be a year later. And that these attacks keep coming. So that's relapsing remitting. So relapse, you get symptoms. Remit, you improve. Then there's a type called primary progressive, which is about 12% of MS patients. They decline and they don't actually ever improve, and they don't really get attacks, so to speak. They just have a slow decline. And that's truly the worst kind and also the hardest for us to treat.
So with all these different types of MS, what can the progression of MS look like?
Yeah, it's so variable. MS might affect someone's vision more, and another person it might be balance or coordination. It can affect cognition, so thinking and problem solving, word finding, things like that. And so if you had a dozen MS patients together for the first time talking about their disease, you could almost think it was different diseases. And historically, there was some of that. They weren't sure that they were all, they thought it might have been more than one disease because people presented so differently.
Does that impact diagnosis or getting a diagnosis today for people with MS? Is that diagnosis process difficult because there's other things that they have to rule out? What does that process look like?
Well, I think we're much better at it than we used to be. First of all, there was a time, it was before my time, where MRIs didn't exist, or when they did, they were harder to access. And so they're much easier now that, MRI is available. Also, the word is out more, and it's part of what we're doing here today, because now that we have so many treatments, it's more important that everyone is aware of it. When there really wasn't any good treatments, then the pressure wasn't on healthcare providers to sort a disease out, because what would you do differently? And once treatments became available, then the pressure was on to sort out the diagnosis early. And data has shown that the earlier you start treatment, the better you are in the long run.
How exactly is MS diagnosed?
Well, it starts with a symptom, and some of the most common symptoms are vision loss, double vision, numbness, perhaps on one side of your body or the other. It could be face, arm, and leg, or just arm and leg. You could be numb in ways that most people, even a lot of healthcare providers, don't understand. Like, it could be numb from the chest down or the waist down. Or you could have just bladder or bowel control problems. And so when some of those occur, let's say bladder, a lot of times the patient doesn't know whether this is somehow normal, it's related to having children, is this an age thing? They don't know, or they're embarrassed to bring it up. But really, when you've lost vision, if you've had a symptom that sounds like it has something to do with the nervous system, and it's continuing for 24 hours or longer, somebody should hear about that story and pay attention. Because if you lie funny on your arm overnight, you wake up and it takes 20 minutes, you get your arm sensation back, that's not going to be an MS attack. It has to be present typically for 24 hours or longer. And I've participated in research studies where they required the attack, so to speak, to be 48 hours. So that would be double vision or droopy face or vision loss in one eye for 24 or 48 hours continuously or longer.
You mentioned improved treatments, which is exciting. That's an exciting thing, that there's progress in treatment and diagnosis. What are some of the treatment options available for MS?
Well, so there were no treatments really until 1993. And the first treatment was so hard to get that there was a lottery system. So your provider could put in a request, and then you get on a wait list, and then a lottery was done. And this was in 1993.
Oh.
And so we went from one FDA-approved drug in 1993 to now many, and they work in different ways. We call it the mechanism of action. How does a drug work? And but then we can also categorize them based on low, middle, and high efficacy. And even from the beginning of high-efficacy drugs, like 2004 through 2006, I used them. And there was even some blowback occasionally from people that I ran into, thinking I was treating maybe overly aggressively, that there was a theory out, you start with the lowest efficacy drug, and then if you develop disability, then you'd go to a middle efficacy drug. And then if you developed disability, you would go to a high efficacy drug.
And sorry, when you develop the disability, does that mean the drug is no longer being effective? Or what does that mean?
It's not achieving our goal,
Okay,
for sure. But that was wrong way of thinking, really, because you don't want to wait until someone worsens and then add a drug, because you might not get any of that function back again. So really, for the last 10 years or so, the thought has been to go to high efficacy medications right from the get-go. And that studies have shown that when you start high efficacy treatment early, that even versus, say, middle or low efficacy treatment, that even in 2 years' time, there's a statistically significant difference between the people who went directly to high efficacy drugs compared to people who were in middle or low efficacy drugs. So again, it's important to make the diagnosis early and then really get on what turns out to be the newer drugs, higher efficacy drugs. And so that's what's mostly done actually now. Most everyone's kind of caught up to this. And so the higher efficacy drugs tend to be used right off the bat.
Another thing we came across in our research was disease-modifying therapies. Is there anything you can tell us about that?
Yeah, so that's the drugs we're talking about. So let's say you took a drug that helped you have a damaged nervous system, and you took a drug to kind of goose it up a little bit and get a little more function out of it, maybe like a stimulant. You're not fixing the problem. You're just treating a symptom. Or if MS caused you to have a tight or spastic arm or leg, you could be on a drug like baclofen, which would reduce the spasticity, but isn't actually doing anything to prevent or slow the disease. So a disease-modifying therapy are drugs like the ones I was alluding to that really dramatically reduce, for instance, the chance of a new MS lesion showing up on MRI. I mean, when I mean dramatically, I mean some of the lesions are reduced 95% compared not to placebo, but to one of the older drugs that we don't really use much anymore. Head to head, the newer drugs just are just tremendous. They outperform the old ones to a level that you can't compare. 95% reduction in MRI lesions. We're getting to where it's kind of a surprise when new MRI lesions pop up.
There's no specific cause for MS, right? Correct?
Correct.
But are there factors that have been identified that could lead to MS?
Yes, there has been. The most important one is probably related to sex. The women, tend to get more autoimmune diseases, not just MS, but lupus and Sjogren's and rheumatoid arthritis and Hashimoto's thyroiditis and a lot of other autoimmune diseases. We're not sure why. There has been theories that perhaps women outlive men in part because they have stronger immune systems, and that's the good of it. But that, unfortunately, if your immune system is too powerful and makes a mistake, maybe say the word screw up. If it screws up, then unfortunately you take the brunt of that. So that might be part of what's going, well, we know that to be a part of what's going on, but we don't know why. As far as where you live, the further north you live, particularly in the first 20 years or so of your life, the higher your risk. And we're not sure exactly why. I mean, the problem is there's a book about biases in good people. So you can be biased and think and not realize that you're biased. Mm-hmm. And so one reason this data could be biased is because historically people from Northern European people, they would move to the northern parts of the U.S. and the southern parts of the U.S. Might attract a different group. And we're talking about whether, 1800s or 1900s. So immigration patterns, if it's more common in northern Europeans, when you look at data from, say, Olmsted County, Minnesota, and that data is really important, MS data. They've been collecting data there for 50 years or more on MS. And the Olmsted County data, it looks like, that this is mostly a condition that affects, it's from northern areas. Well, is it because they're northern, or is it because they're, a group of people from, European
descent?
And which one is it? So you could think, boy, it really looks like the problem has to do with where you live. And maybe it's immigration patterns. So it's hard to know. Another example of these biases is, for the longest time, well-meaning people have said that Caucasians got MS more than African Americans did. And we're learning that that's probably not true. Their access to healthcare was different. And so so that data looks like it was probably biased, and that's not the first time. So then vitamin D exposure, very important. And it seems that deficiency in vitamin D, which the further north you live, the less likely you are to get natural vitamin D, which is going to be, ultimately from the sun. And so we don't get as much sun. And the sun we do get is less direct than, say, if you were, in Miami, Florida. Well, and the numbers actually bear that out. So the incidence of multiple sclerosis, the closer you are to the equator, is reduced compared to the risk the further north you are. And so vitamin D, migratory patterns, maybe. And then another important one is Epstein-Barr virus, which is the virus that causes mono. And it looks like that virus may predispose us to getting autoimmune diseases, but particularly MS. And so doesn't mean if you had mono that you're going to get MS. It just makes the risk a little higher. And so it seems like even people who got really bad cases of mono are potentially at a little higher risk than, say, people who got mono and didn't even realize it because it was so mild. And so there's another factor. Patients frequently worry when they have the diagnosis that their children are going to get it. And the risk is about 6%. And that's much lower than they think because most of us know only what's known as Mendelian genetics. So, this gene and that gene and half are carriers and that's like a simple example of a single gene.
Is that like with the square?
Yes.
Is that what you're talking about? Okay,
Yeah.
Have to reach far back in the memory for that.
Yeah, and that comes from
junior high science class.
Yeah, exactly. That's what most of us know, right?
Mm-hmm.
But it's actually many genes. And in fact, in identical twin studies, if your identical twin gets it, your risk is 20%. And so that's because they get pretty much all of the same genes. And so more likely than, 5 genes or 10 genes, it's probably a higher number than that. And then you get exposed, perhaps to Epstein-Barr virus. Maybe you're deficient in vitamin D, and the combination kind of brings it out.
That does seem a little tricky to know with so many different factors to really know what the true cause is. But that's cool that there's research going on to try to figure out.
Yeah, for sure.
What role does physical therapy or lifestyle management play in living with MS?
Lifestyle management, I think one of the best things we can do is keep our weight down, something I've not succeeded in, but a lot of people do. And it makes it easier for a few reasons. So one is it looks like you're less likely to get MS if you're normal weight. Now, the difference is so subtle. I don't want anyone who's overweight and has the diagnosis of MS to think somehow this is their fault. We're talking about the most tiny increase. And so keeping your weight down has that advantage. But then once you have MS, if you have a balance problem for MS, then being overweight is going to make it easier to lose your balance. And if you were to fall, it makes it less likely that you're going to hurt yourself. And so, physical therapy for balance and conditioning and such can be pretty helpful. Remember, most people who get caught early do so well that, most don't really even need physical therapy.
I was thinking about yesterday, we were talking with another guest, and she talked about exercise was like a big thing, and then also eating right. So it just seemed like taking care of yourself like you would normally would help too. Is that a lifestyle choice that kind of helps?
So there have been books written and people have made money selling books like the MS diet and so forth. But really, when the books that are reasonable pretty much are saying, eat in moderation. don't go all caveman and eat nothing but meats, and don't necessarily eat nothing but veggies. I mean, that can be a very healthy lifestyle, but you have to do it right. The average American's just too busy to actually learn the importance of being a good vegetarian. You know, there's some cultures, like in India, they've had so many thousands of years of vegetarianism that they're good at it. I mean, it's just like, you know, they don't have to go and look up what's the right bean to get this essential amino acid, because that's what mom served and grandma served and grandpa and everybody. And so, we kind of do crazy stuff like just get a wild hare and say, that's it, I'm not going to eat X, you know, or I'm going to eat only meat that I kill or something crazy like that. And so most of the data just suggests eating in moderation. And I think that's what I tell my patients to do.
Are there any recent discoveries relating to MS or current research that is being done?
Well, they're always doing research. So as far as questions that my patients are almost always going to ask, if not on the first visit, in the first couple of visits, is there any research going on in remyelinating? So if multiple sclerosis is an autoimmune attack that strips the insulation off your nerves in your central nervous system, can you put them back? Can you put it back on? So that's remyelination. And that research is going on all the time. And it just hasn't come up with anything solid yet. There looked to be some close calls. There was a drug years ago called anti-lingo. It looked very encouraging. It worked on guinea pig and rat spinal cords and things like that. And then it just didn't work on humans, sadly. But they're constantly working on it. So there's multiple steps. You know, when we're born, we're not fully myelinated. We're barely myelinated. So we have nerves, but they're not. They don't have the insulation on them. It's part of why, like, babies' eyes don't track very fast. If you put your hand up and they look at it, and then you move your hand quickly, they lose it because their nerves don't fire as fast, and that's because they don't have the insulation. Well, we then start insulating, you know, in earnest, and we're not fully insulated till about 25, which explains why, especially guys, punch walls and do other stupid things because they're not fully insulated, and they finally do. Well, once that happens, you know, once you're fully myelinated, you have to tell your brain, there has to be a mechanism to tell your brain to stop myelinating, because otherwise you'd grow tumors on those nerves. They're called myelin sheath tumors. So you have to say, okay, you're done. And that's one of the steps involved is this lingo molecule. And so they said, if this stops it, then if we get an antibody to it, maybe that will start it again. And as I said earlier, it didn't work, but they're really working on it. And so we can hope.
Well, it's fascinating. And I didn't know that about that our nerves aren't fully myelinated until a specific age. So that's so cool that they're thinking, okay, there's got to be something, it turns it off. There's got to be something that maybe can turn it back on to fix it.
Yes.
Are there any misconceptions about MS that you'd kind of like to clear up that people don't understand fully?
Well, I want people to know it's not their fault, you know, and it's not because they ate too much of this or not enough of that. You know, there may be little trends. It'd be nice if people would, especially who live in the north, would take a little more vitamin D. But, you know, I think it's important that they know that it's not their fault, that it's not primarily genetic, that if they have it, their children's odds are about 6%. Okay, that's typical. I mean, that's overall the typical number that's quoted. And so I'd like them to know that there's a lot of scam artists out there, and a lot of them are in this area, and they will say they're doing stem cell. Well, you know, stem cell, the way it is being done and has been shown to help, still not ready for prime time, still not FDA approved. But in that scenario, what you're talking about is taking your stem cells out, typically a bone marrow biopsy from the hip, processing it, and then they would give you like a chemotherapy to knock out your whole immune system, keep you in a little, a special room to keep all the bacteria and viruses out. And then once that chemo's out of your system, they put your stem cells back, and that repopulates your immune system. So it changes your immune system. That's what real stem cell therapy is. This other stuff includes people going, hocus pocus and rubbing on you and doing stuff that we're talking about. People around here doing it who are not doctors, nurse practitioners, PAs, nothing. They're just doing it. And I did have a patient who spent $40,000 on this. Now that patient could have seen me for years and years and years, 4 times a year, and would not have hit that bill from me. And yet somebody who's not allowed to do surgery or really draw blood or do anything, unfortunately, suckered them into it. So they need to be really careful. I like my patients to know, and I'll write it down for them, that there's a website, nih.gov, National Institute of Health.gov. And when they're interested in something, they should search on that. I know there's some, kind of anti-government sentiment in America, but I think the NIH does a good job, and I don't have any reason to think they're biased. And you can look up anything there. That's the other thing, is that your interest may not be MS. You may have a family member that has some other condition, and you want to know a little bit about it. Now, it's going to be in medical speak, but that doesn't mean, you can't either figure it out or you copy and paste it into an AI like ChatGPT or Perplexity or something and say, explain this to the level of a high schooler. And it'll then convert all that into plain English, which is really a nice little thing. It's, AI, I know it's kind of a big thing, and there's lots of stuff thought about what it could do, good or bad. But in this example, taking complex medical information and just pasting it in and then say, explain this to me, and it does it. It's really quite nice. So it can take medicalese kind of terminology and NIH.gov and put it into layman's terms.
Yeah, learning all you can about it, definitely.
And by the way, people will apologize and say, "Oh, I'm sorry, I looked this up on Google." That's my job, is to, answer their question. I don't care if they got it from Google. And it's like, your job is to worry about you, and my job is to worry about you. And so, I don't care.
You've got to start somewhere, right?
Yeah, if you bring something in from Google, you don't apologize. Just bring it in. It's it's worth asking.
Use good resources, reliable resources, and ask questions.
Preferably .gov, .edu, .org, maybe a little more than .com.
Yeah, for sure.
What are some of the struggles that people with MS face?
Well, one struggle that I should go get to right away is that if you were to, say, lose an arm for whatever reason, people can see it. And so they kind of adapt to it, and they somehow are a little more understanding if you're having troubles doing something. But when you have MS and maybe nothing is visible, but MS patients get tremendous fatigue. It's inherent. If a person isn't undergoing an MS attack at the moment, their biggest complaint is usually fatigue. And it has something to do with the immune system's inflammation and activity. We're not totally clear as to why fatigue is such a big thing. But it's overwhelming, and it's very likely that most of us can't even, just can't understand what they mean. They're so fatigued. And so when someone's having troubles because they look okay, sometimes they don't get very much support. And that might even be from their own family. It's like, you look fine to me. I can't believe you're just lying around. But the best I can come up with is if you can remember what a fatigue feels like when you have the flu, you feel, quote, weak as a kitten. you're actually strong. If I actually gave you a dynamometer to like squeeze and show what your grip strength was, it would still be okay. So it's not that you're actually weak, but it's an intense feeling of weakness. And like I said, it's unlikely anyone here hasn't experienced that with a flu. And that's the closest any of my patients have gotten to explaining to someone like me what it feels like to them. So you can't see it, and yet they're somewhat incapacitated, and they don't get the concern as much as someone who has a visible problem. So I don't know if you have any other questions related to that, but that's an important one, I think.
I do remember that a little bit in the research. It was what did they call it? Well, you look fine. I can't remember what they called it, something. But it was the same sentiment. Like, well, you look okay. Like, you look like you're doing great. But like you said, the fatigue, balance issues, you don't always see those. Or like pain and numbness and tingling sensations. So yeah, that's definitely got to be a struggle.
But by the way, the balance problem can be interpreted as you're drunk. In fact, this is someone so long ago, none of you know who I'm talking about, but there was this actress, from like the 50s or 60s maybe, and her name was Annette Funicello, and she had MS. And one of the tabloid papers was putting out something about how she was drunk. And so before they published it, they wanted a comment from her, and she just felt then obliged to tell everyone she had MS. So she didn't want people to know that. But you can have MS and stumble or maybe drag a foot a little bit into someone who doesn't know how to observe a gait, which I do. So I can tell the difference between stumbling because I have, a problem with my cerebellum versus, transient stumbling due to being drunk. And but most people can't. So they'll project really concerning and erroneous explanations for why a person's struggling.
Seems it's better to just be kind, because even if their symptoms, obviously their symptoms probably are way worse than you could ever comprehend, but even if they're not, it's better to just be nice if someone's struggling. So
yeah.
How have you seen families and friends support their loved ones with MS? How is it best to go about doing that, especially with something they can't always see or understand?
Well, first I would say ask them. Okay, because now this seems to be more of a male reaction to this, which is suddenly, if it's the patient's a woman and the spouse is a man, then all of a sudden he's, trying to maybe sell the house and get everything on one level and install a wheelchair ramp. And it's like, the odds of that are incredibly small nowadays. It's like they feel like they want to do something and they don't know what to do. And so, maybe if they were under 25, they would punch a wall because that's, more of a young man thing. But instead they or they treat them like they're fragile little creatures that, that one little move and they're going to crack. And they're not. They're just regular people and, generally scared and don't want to be treated like a delicate flower. They just want to be treated normally.
So that's what not to do. But are there any things that you should do to help support somebody who has MS?
Yeah, but that's the problem is that first answer was ask them because, first of all, they're all different. And they go through phases, especially now with the medicines are so good. So first phase is scared to death. And what they do is they think about people they know, maybe a neighbor or maybe a relative who had it 30 years ago and did terribly. And, we didn't really have medicines. So, and so they're very frightened. And so just emotional support and if you read on something, maybe they want you to do that. Maybe they don't. You know this whole story about how men are always trying to fix things and stuff. Maybe the patient wants to do it themselves. Maybe they're glad to accept articles that you found. Maybe the actual patient's going to like that and think that's a good thing. But you really have to ask. But remember, most of them are doing fine. If you had double vision and that was your first MS attack, with a brief and quick course of steroids, most people, their double vision's gone in 3-4 weeks. Okay. But then, the expectation without treatment is you're going to have more attacks. This is the first maybe of many. And so the person may be absolutely normal, but very, very fearful. So I'm not sure that it's an easy answer. What can someone do if you're in that situation? Just be supportive, and and then find out how they want to be treated. Maybe they would like a few weeks of being treated like a delicate creature, and maybe they just want to go on and pretend like there's nothing wrong. Fake it till they feel it, kind of thing.
You kind of touched on that, the fear and anxiety. Are there other ways that MS can affect someone's mental health?
Well, yeah. So the reason you get your MS symptom where you get it is where the lesion happens to be in the brain. And so if the MS lesion, the inflammation is in the left motor strip on your brain, then you're going to have something, paralyzed on the right side, perhaps. If it's in the brainstem, maybe you get double vision for a little while. Okay, but there are so many structures that aren't visible. So you don't go weak, you don't go numb, you don't have a change in your voice. So you just might have troubles thinking as quickly. You may have troubles finding the right word. It takes that extra second to get it to come out, and so that's the thing. It's affects cognition and balance, and it can cause weakness. And any part of your central nervous system, if it gets hit, you're going to see a symptom based on that. And there are lesions, like a person who gets their first symptom, will scan their brain and see 4 or 5 lesions. And they'll say, how did that happen? And how come I didn't notice it? Because there's parts of your brain that you wouldn't notice. So maybe you would if you're an artist, and you wouldn't if you're a neurologist. Maybe you would not notice it if you're an accountant, but you might notice it if, you're doing research in 3-dimensional shapes of proteins, because some parts of your brain you don't use as much. You can get an attack that if I got it in that location, I wouldn't notice. And an architect might, have troubles, imagining her design in 3 dimensions when she wouldn't have before the attack, and not even realize it until she suddenly realizes she's having a trouble. And she ignores it. And maybe it gets better, because a lot of MS attacks do. And then she gets one that makes her numb, and that's when the diagnosis gets made. But she was actually having some symptoms before. So cognition, memory. So a big portion of your memory function is in the temporal lobes, left and right. And you can get lesions there. Now, it doesn't mean you're going to forget your birthday or something, but it could be harder, for instance, to learn something new. So maybe you're having trouble in school, you're going back to school at whatever age, and you're having troubles, and it could be due to something like that. And again, it doesn't garner sympathy because you're not, limping or anything. You're just struggling a bit. And with the diagnosis, though, you can then go to the college and say, I need tutoring, and because I have this diagnosis, so I need some help taking my class, whether you're taking it in your 20s or 50s.
Is there anything else that you would like to share about multiple sclerosis?
I think the most important thing is that it's so positive compared to the bad old days. You get a lot of people, particularly old people, which I'm part of that group, I guess now, that go on about the good old days. Well, I don't know that they were really as good as most people thought. And this is an example. So, as I say, they look at some neighbor who's been in a wheelchair for 40 years, and think that's what's going to happen to me. And that is actually low probability with modern medications. And so, I'd like them to know it's not a death sentence, and we've got good medicines, and they're actually generally quite tolerable too. There was a time the old medicines, which I don't really use anymore, were shots that you would take daily or 3 times a week or once a week. I haven't prescribed any of those for years and years and years. So we've got drugs that you take IV once every 6 months. And so twice a year. Some of the patients will say, you know what, the nice thing about it is I don't even have to be reminded every day that I have MS because I'm taking a pill for it. I can practically forget until the infusion center calls you up and says, your infusion's coming up. And then that's when they kind of are reminded, oh yeah, I have it. And that's a really good situation. There was a time where patients, if I said, I'll see you back in 6 months, it was not unlikely that they would come back in 3 months because they had a problem. Now people will say, do I really have to come twice a year? And that's fantastic. I mean, the answer is yes. I'm suppressing your immune system so it doesn't attack you. And yes, you need to be monitored, but I really think that's such a positive thing for people to now feel so good about it that they're like, I'm practically bored by this. Do I really have to come twice a year? For someone with my years of perspective, this is a really, really cool thing. So it's not a death sentence.
That is really good and really cool that there is hope and there are treatments. That's awesome.
Thank you so much for coming in today. Thank you for sharing your knowledge and your time with us. We definitely learned a lot, and there's a lot to be hopeful about.
There is.
Please remember to rate, share, and subscribe to the Riverbend Awareness Project.
You can find past and future episodes of the Riverbend Awareness Project wherever you get podcasts or on the Riverbend Media Group podcast page.